All right, I'm going to go ahead and get started. It's 9 o'clock. Welcome to the Trio Maryland virtual transplant journey. We look forward to a program filled with great information and takeaways for everyone participating. To open the event, we're going to welcome Marty Marin, President and co-founder of Trio Maryland, and Charlie Alexander, President and CEO of the Living Legacy Foundation.
Good morning and welcome to Trio Maryland's first virtual transplant conference. And we are so glad to see all of you here today for this educational event. I am Marty Marin, the president and the co-founder of the Maryland chapter of Trio, which stands for Transplant Recipients International Organization. I am also a liver recipient November 2009 from the Johns Hopkins Hospital. And I will forever be grateful to my donor for this second chance at life. After my transplant, I started volunteering at the Johns Hopkins Hospital and at the Living Legacy Foundation. And it was during this time that we were able to establish the Maryland chapter of Trio. Our mission is to connect transplant recipients with one another, to provide education on transplant topics, and by offering non-clinical support, we complement the services of our healthcare professionals. We offer monthly educational meetings, and we have hosted 5 in-person conferences over the last 8 years. Please check us out on our website at www.triomaryland.org. And now for the thank yous. I would like to thank the Trio Maryland Board of Directors and Trio, our web hosting company, for all that they did to create this event. I would like to thank our partner, the Living Legacy Foundation, and our hospital partners, Johns Hopkins Hospital, and the University of Maryland Medical Center. I would also like to thank the presenters for all their time and for sharing their knowledge on these very important transplant topics. We have wonderful sponsors that are involved with our transplant community, and we wouldn't be here today without their support. Thank you to all our sponsors. Don't forget to check out our sponsors and their websites. You'll find them on our sponsor tab on our registration platform. Thank you again, and we hope today is informative, educational, and helpful as you make your transplant journey. Good morning and have a good day.
Hello, my name is Charlie Alexander. I'm the president and CEO here at the Living Legacy Foundation of Maryland. I want to welcome all of the Trio members to this event and just say a few words on behalf of the Organ Recovery Program serving most of the state of Maryland here. The Trio has been a valuable partner of ours for years. There's no more compelling message ever than to hear those patients and their families who've been impacted by the gift of organ and tissue donation. You are our great stewards, you're our great spokespeople, and we get up every day and come to work in service of you and your families. Now, the Living Legacy Foundation is the organ recovery program here, again, working most closely with Johns Hopkins Hospital and the University of Maryland Medical Center. So we're working with families who are arguably going through some of the worst days of their lives, faced with the prospects of saying yes to organ and tissue donation. And we are thinking of you every time we sit with those families, advocating for our waiting recipients and serving our donor families. So thank you for what you do. Thank you for the courage it takes to be an organ and tissue transplant recipient. I have a longtime friend of mine all the way back to days of middle school who received a kidney and pancreas transplant, and she reminded me every day following her transplant that being a recipient isn't for sissies. And I watched her work hard to be a perfect steward of that gift and honor that donor family. And to me, that's humbling, and that really defines why we do what we do. So thank you again for being a part of this day. I hope you learn a lot and you can share a lot with others going through the same transplant journey that you're going through. And again, best wishes for good health and a great 2021. Thank you.
What a great introduction and a great way to kick off the 2021 event. Trio Maryland is excited to be bringing you this conference virtually. I have a few quick reminders, and I'm going to share with you some housekeeping. So this webinar is being recorded. Recordings will be sent to participants following the event. We also are hosting a general meeting room, which will be open following this session from 10 until 12. The link to this general meeting room will be available in the chat box at the end of the session. If you need any support during the event, please text 410-635-0229. We also have the possibility for comments and questions. Please use the Q&A feature in your Zoom settings to ask questions, which will be answered by Michelle at the end of the session. And then the chat box feature is where you can communicate with other participants. This is a webinar format, and you will not be able to see or hear the other attendees. We're here to discuss preparing for your abdominal liver transplant, presented by Michelle Morrison from the Johns Hopkins Hospital. Michelle is the lead kidney and pancreas transplant coordinator at the Johns Hopkins Hospital. She's worked at Johns Hopkins Hospital for 11 incredible years. Michelle graduates in May with her master's in nursing education. She is very passionate about educating potential transplant recipients and their families to ensure the best possible outcomes after transplant. Her ultimate goal in her career is to touch the lives of each and every patient that she encounters and to make them feel comfortable and at ease during an incredibly vulnerable time in their life. And I will let Michelle take it from here.
Awesome. Thank you so much. I was wondering if I could see the results of the poll. For some reason, I can't.
Okay, so the results of the poll, to those that answered, we have, are you waiting for a kidney transplant or a liver transplant? 61% said kidney and 39% said liver.
Okay, awesome. Thank you so much.
Sure.
So I will share my slides here in just a second, but I just wanted to thank you all so much for being here today. Thank you all for having me. I am very excited to talk with you about kidney transplant, liver transplant, and pancreas transplant today. So I'll share my slides in just a minute, but just a little bit about myself. I know Rachel gave a little bio, but I have been a Hopkins nurse for 10 years, working for the hospital for 11. And it's been wonderful, incredibly humbling experience. I'm very passionate about transplantation, but actually more importantly, I'm really passionate just about patient education. I truly believe that the more that you know and understand about your health, the better that your outcomes will be, regardless of what health issue you're going through. Obviously, today we'll focus on kidney transplant, liver transplant, pancreas transplant. But I do think it's really important just to be educated about what's going on with your health, just be knowledgeable about it. It is 2021 and medicine has come a long way. As I'm sure you've been told many times before, transplantation is a journey like none other. It's truly a journey like none other. I am very passionate about being supportive and being a resource for my patients. I know that not everybody who's tuning in today is a patient at Johns Hopkins. I know some of you are listed at Maryland, and then I know there's a lot of surrounding transplant centers. So obviously I am here at Hopkins in my office, and so I know I see some familiar faces, some familiar names, and but I know that not everybody is listed at Hopkins. So I'm going to speak very general about kidney transplant. And then I also work with a bunch of incredible people. My team is just so supportive. My team is encouraging, compassionate, very educated about the transplant process. I think a mutual goal here that we all have for each other and I have for you is just to get a transplant. You don't need to get a transplant at Hopkins. It doesn't need to be from a deceased donor, live donor. I just want you to get transplanted to give you a better quality of life. So I am going to share my screen here. There we go. All right, so like I said, we are going to discuss today kidney, liver, and pancreas transplant. we decided to name this whole session the Preparing for Your Abdominal Transplant, because as I go through, you will kind of realize that there's a lot of similarities. We're going to go through what each organ does in the human body and why it's important. So why do you need your kidney? Why do you need your pancreas? And why do you need your liver? We'll kind of go through the process on what it means to be evaluated for each different organ transplant, what it means to be listed, things that we think are important to prepare for after you receive a transplant. I am going to leave about 15 minutes at the end of the seminar just to answer some questions. I am a talker. If you are my patient, you probably know that. I can go on soapboxes, so forgive me if I do run over a little bit. I will go to the general Q&A meeting room after this as well, so I'll be available until about like 10:15 or so today. And then at the end of this presentation, I know Rachel posted my email, but at the end, I will hold a slide up that has all of my contact information on it. My email, my phone number. Again, I know not all of you are listed at Hopkins, and I know that, but if you're interested in coming here, you can reach out as well. And another thing I just wanted to say is that I hope that you leave here today just knowing that you're not alone in this journey, and there are so many resources and support. You just have to know where to find them. And so I just want you to know that you're not alone in this journey. Your nurses are here for you, your coordinators, and then there's a lot of other patients going through this. So that is my goal for today. All right, so we are going to focus on kidney transplant. At the beginning, you will notice that there are a lot of similarities going across the board, but we'll talk just why your kidneys are so important. So I know that a lot of you are on different phases of your transplant journey. I think some of you are on dialysis, either hemodialysis or peritoneal dialysis. Some of you are waiting for a dual organ. Some of you are waiting for a kidney and a pancreas, or some of you are waiting for a kidney and a liver. I saw somebody in the chat box said they are waiting for a kidney and a liver. Some of you are donating your kidney. Some of you might be donating part of your liver. Some of you might be the recipient of a live donor that is currently scheduled. So in the next month or so, you could be looking at a transplant. Some of you have a really solid understanding of why your kidneys have failed, or your liver has failed, or your pancreas is failing. And then some might just be starting out your journey and still trying to, understand this process or understand why you are in the situation that you're in. So I want to go back to basics here and understand why they're so important. I think if you understand the basic functions of these organs, it will help you manage your symptoms after transplant. So first of all, your kidneys, you can read up here on the slides, they remove waste products from the body. They remove drugs from the body. Drugs could be illegal substances, but when we say drugs, a lot of the times we're talking about different pharmaceutical agents. When you were diagnosed with kidney failure, you were probably told to stop taking NSAIDs or non-steroidal anti-inflammatories, and that's because those specific drugs like ibuprofen, they're directly filtered out by your kidneys. And so we want to try to preserve the life of your kidneys as much as we possibly can. So we're going to tell you certain drugs that you should not be taking. They balance the body's fluids. They release hormones that regulate blood pressure. They produce an active form of vitamin D that promotes strong, healthy bones. And they control the production of your red blood cells. So when your kidneys are not working, you can kind of understand why you're maybe feeling the way that you're doing, or way that you're feeling. Feeling very sluggish, likely because you've got a lot of buildup of toxins in your blood. Just feeling very swollen. You probably know when you go to the doctor, they look at your legs, like your shins and your ankles, to make sure that you don't have too much swelling, because gravity is obviously pulling that fluid down to your ankles. And so you might be feeling really, really swollen. You might have a hard time taking a deep breath or just catching your breath. And a lot of the times that is from the different, just retaining a lot of fluid. You could have it around your lungs or in your lungs. If you've got like an active cough or like a wet cough, it could just be because you have a lot of extra fluid. And then a lot of you are probably suffering from anemia or a low hemoglobin. A lot of you are probably prescribed medication to increase your hemoglobin, and that's because your kidneys, when they don't work, they're not controlling the production of your red blood cells. And so that is causing a decrease in your hemoglobin. So obviously your kidneys are very important because they do a lot of different things here. And so next I kind of want to shift and talk about kidney transplants specifically. So like I said, a lot of you are in different parts of your journey. And so a lot of you might know this information, but some of you, this might be new. So there are 99,000 people waiting for a kidney transplant in the United States. That is a lot of people, but it gives a whole new perspective on, like, you're not alone in this journey. So that is nationally. We do not have that many people at Hopkins waiting for a transplant. At Johns Hopkins, we have our wait list is about 1,500 people, give or take, at one period of time. And we usually evaluate about 100 new patients every single month for a kidney transplant. The average wait time for a deceased donor transplant, we will talk a little bit about live donation, but the average wait time for a deceased donor kidney transplant is an average of 3 to 6 years based on your blood type. This is one of the main differences between kidney transplant, liver transplant, and pancreas transplant. The wait time for a kidney transplant is very specific to that. Each year, 5,000 people die while waiting for a kidney transplant, and about 20,000 kidney transplants are performed annually. This is 2020 statistics, of course, so this would change from year to year, but more people are waiting for transplant as the years go on. And a lot of people want to know why. Why is my wait time so long for transplant? Well, two reasons, main reasons. One, we have a national shortage of donors. There's not a lot of people in the United States that are donors, and a lot of that just comes down to education. It's not nationally mandated that everybody is an organ donor. You have to declare that when you get your license or some sort of government issued ID. And then Americans are getting sicker and sicker. Most of it's diet. We have a lot of diabetes and hypertension and obesity, which makes them not the best candidates to donate your kidney. A lot of you could potentially be waiting for a kidney transplant because of high blood pressure and diabetes, or one or the other. So you know that both of those comorbidities directly impact your kidneys. And when somebody passes away and they have had the comorbidity of hypertension or diabetes, it just does not make them the best candidate to donate. So there is a long wait period for kidney transplant, I should say. So kind of moving forward in this process, being evaluated for a kidney transplant is what my team is doing here at Hopkins. And I just, one of the things that we want to make sure is that a patient fully understands the benefits, risks, and alternatives, and you are able to make an informed decision on whether or not kidney transplant is the right option for you. The alternatives to kidney transplant is dialysis. So, obviously not everybody wants dialysis. I don't know a lot of people that want dialysis. Pretty poor quality of life. And so we are here to evaluate the benefits and risks. My team is going to decide, based on a lot of different factors, if transplant will benefit you or if transplant will be too risky for you. The benefits: longer survival, improved quality of life, living life without the requirement of dialysis, and overall you feel better. So the benefits of transplant are simply to give you a better quality of life. But the risks of transplant sometimes outweigh the benefits. First of all, it is a surgical procedure. It's a very technically challenging surgical procedure. So we want to make sure that your heart and your lungs are able to undergo the whole surgical process, anesthesia, the stress on your body of surgery. So our team will do an echocardiogram and a stress test just to make sure that your heart and lungs are able to undergo anesthesia. Lifelong immunosuppressant medication. I believe that there is a today you're going to listen to someone discuss at length the medications, because that is a huge part of the post-transplant journey. But everyone will be prescribed a medication that you are going to be on the rest of your life. Those immunosuppressant medications, I know immunosuppressant is a long word. If you break it up, you can see the word immune, which is like your immune system, and then suppressant, which means to decrease. So you are going to decrease the functions of your immune system. So that way your body's natural response is to reject or not want the kidney that we put in, because you were not born with it. It thinks it's a foreign object that's in there, and it's wants to fight it off. So we have to give you medication so it doesn't fight that kidney away or that organ away. But the immunosuppressant medication does come with a number of side effects. And then there's the risk of rejection and graft failure. Rejection is when your body's natural response is to reject. That's either because you are not taking your medications as prescribed, or your body is, your immune system is just really strong and it is trying to fight the kidney away. Graft failure is when the kidney just stops working. And that sometimes happens sooner rather than later in some patients, which we'll talk about in a bit. And then you're going to have a risk of malignancy, which is another word for cancer, and infection. Both of these are because the medications are suppressing your immune system. So if you have any type of precancerous cells in your body, or the immunosuppressant medication is, your immune system is currently trying to fight those off. And when you're taking that medication, your immune system is not going to fight off all of if you have any precancerous cells. Infection, your immune system is going to be suppressed. So any common colds, common virus, anything that you get exposed to in the community, your body is not going to be able to fight it off. So you have to be very, very mindful of this after transplant. Truly, I will go back and say it over and over again, that transplant is truly like a journey like no other. So our goal when we evaluate is just to understand the benefits, risks, and alternatives. Have our patients understand the benefits, risks, and alternatives, and then for our team to outweigh if the risks or benefits outweigh one or the other. So a little bit about the kidney transplant waitlist. There's two different statuses. There's an active status and an inactive status. So active status is when you're cleared for organ offers and accruing time. Inactive, and I put the status 1, status 7, because that's what it is in the United Network of Organ Sharing. Inactive status is when you're accruing time, but you're not eligible for organ offers, possibly due to pending tests or current medical, financial, or psychosocial status. If you are listening to me and you are not sure of your status on the wait list, we tell you your status of the wait list at the time. So you should be getting a letter from your transplant center just saying, you are actively listed or inactively listed. So if you're not sure, I encourage you to reach out to your transplant coordinator just to determine what your status is on the wait list. Obviously, it's important to be actively listed. If you're inactively listed, there's a reason why, and you would want to work with your coordinator to make sure that you could, become active on the transplant list. There are a number of reasons why patients are not candidates for kidney transplant. And this is one of the worst and hardest parts of my job, to be honest. I hate having to tell someone that they're not a candidate for transplant. There's always a range of emotions, and I always tell them that, you can always get a second opinion. But there are reasons why transplant is too risky. We want to improve the quality of your life, not decrease the quality of your life. And if you have any of these possible contraindications, plenty of literature points to your transplant outcomes not being very good, and hence giving you a poor quality of life. So we would not give you a kidney transplant. Advanced cardiovascular disease is unfortunately a very common problem for patients who have diabetes, longstanding high blood pressure, or just someone who's been on dialysis for a very long time. Active malignancy, that means we can't transplant you with an active form of cancer. Active substance abuse, this is I believe, a policy that's specific to Johns Hopkins, but you could check with your transplant center. We don't like when you're actively abusing any substances. I think one that comes up very common, which I will not discuss at too much length, but is medical marijuana. We take that on an ongoing, on a case-by-case basis. And then a prohibitively high body mass index. Your body mass index is abbreviated as BMI. That is a height to weight ratio. You can literally Google BMI and a calculator will pop up. You'll put your height and your weight in that calculator. Anything over 40, we will ask you to lose weight. We don't like to transplant patients over 40 for two reasons. One being the surgery, when you have a very large abdomen, when the surgeon goes to close your belly, you have a lot of tension on the sutures, and that increases your risk of either having that wound open up or that incision open, which is obviously a huge risk for infection. And it also just increases your risk for infection. And then also having a high body mass index prior to receiving a kidney transplant, some of the medications that we will give you, the immunosuppressant medications that we'll give you after transplant, will cause or could cause some weight gain. So if you're already in the morbidly obese category based on the BMI scale, we will ask that you lose some weight prior to transplant. And then just a little thing at the bottom, I think it's important to touch on that you should be sending in samples to your transplant center if you're actively listed, sending blood samples in. On a certain schedule. It's different for everybody, but I do encourage you to reach out to your transplant center if you haven't heard from them, if you're actively listed and you haven't heard from them about how often you should be getting your samples drawn. It's important to make sure that you're keeping up with that. For Johns Hopkins, we send them directly from our immunogenetics lab, which you can contact directly, and they'll send you kits. If you're out of kits, you just have to order more, but it is very important to keep that blood sample up to date while you're waiting for a kidney transplant. So just speaking a little bit about live donation, obviously there are a number of people in the world willing to give you a kidney transplant if you share your story. Live donor kidney transplant is truly the gift of life. Transplant is the gift of life, but getting a kidney from a live donor is a huge, it's just a very generous gift. You don't need to have the same blood type to donate. I always start out with this because there's a lot of different options for patients, and a lot of my patients come to me very focused on their blood type. So it's important to know that you don't need to have the same blood type. We are active in the paired exchange program. So we have that as an option. There is an option to do incompatible. And then of course, there's always the option if you're the same blood type to do direct donation. We do sometimes have patients that come to us, donors that are interested in donating a kidney, but it is not directed towards any particular person. They just felt like out of the goodness of their heart that they wanted to donate a kidney. That's called an altruistic donor. I put a little chart up here as well that says covered and not covered. So these are the expenses that are covered and not covered for a donor. Evaluation visit, diagnostic blood work, diagnostic tests, surgery, and post-surgical care. Not covered are travel expenses and unrelated medical conditions, which don't come up too often, but they do come up. So just keep in mind that we don't cover that. A lot of my patients want to know how they find a live donor. I wish that there was some magic button I could press and all of a sudden people will start coming forward for my patients. But unfortunately, that's not always the case. The biggest thing that we talk about is just sharing your story. We do have this app called the Donor app. It is like it's in research phase right now, but sign up and list Johns Hopkins as a transplant center and you will be called for further instructions. It'll an app that will help you write and share your story. You can just Google the Donor app and Google and it'll come up for you. Social media platforms. I know not everyone is big on social media. I totally get that. But if you have any friends or family that are, that are very active on social media, they could definitely share your story. All you have to do, of course, I know not everyone's listed at Johns Hopkins, but if you are, all you have to do is contact the donor team at 410-614 3873. Actually, I'm sorry, guys. It's 410-614-9345. I'll edit that slide out. And then you can also Google the kidney transplant, Johns Hopkins kidney transplant live donation, and the website will come up for you to apply to be a donor. You can share all of this information on the website or on your social media platforms, because it really helps people kind of understand what you're going through. And also they can come forward anonymously. You do not have to have someone come forward as a donor. That you don't have to know your donor. So shifting a little bit just to talk about organ offers. So kidney transplant organ offers are allocated based on how long you've waited on the wait list. It's driven by the date of first dialysis. If you are called for an organ offer, keep in mind that a few other patients are also called as well. We have a target patient, which is the first patient. You will be told that you are the targeted patient. Anything happen on the way to the hospital or when you get to the hospital, maybe your labs don't look so great. So we always have a backup in the event that the organ offer does not work out. And then that's why it says at times patients are called into the hospital for tight time constraints, but later discharged. Anything can happen during that admission. Sometimes the surgeon views the kidney upon arrival and decides that it is not transplantable. You could be brought in as backup and never get the organ. So there's no penalty for declining an offer as well. But I think the takeaway from this information, kidney transplant organ offers, this is a little different from other organ offers, but because there's an alternative to kidney transplant, which is dialysis, that is why kidneys are allocated based on how long you've waited, which is why the wait time is very long. There's a lot of people waiting. It's not based on how sick you are, which we'll talk about liver transplant in a bit, but kidney transplant is allocated based on how long you've waited on the wait list. If you're not on dialysis, you do qualify for kidney transplant when your GFR hits 20. So a lot of you were preemptively listed for a transplant. And then some of you came forward when you started dialysis, or maybe you've been on dialysis for a bit, and then you were educated about your options and transplant came up and you became interested in that, and then you came forward. So your listing date went back to the day that you first started dialysis. And if you aren't on dialysis, your listing date starts from the time you're listed either inactive or active. You do not have to be actively listed. You can be inactive to accrue time. And then just a little bit about preparing for after your kidney transplant. You will be started on a number of new medications, which we will be discussing at another portion of this conference. JP drains are Jackson Pratt drains. You're going to have 2 to 3 drains when you're discharged from the hospital. They are put around your belly, around that kidney, because after you get a transplant, it is a surgery and your body is going to produce a lot of extra fluid as just part of the natural healing process of your body. So we put drains in there so that way that extra fluid that's around the kidney can drain out. Those don't stay in for too long. The hospital stay is around 4 to 7 days. You are going to be assigned a post-transplant nurse coordinator. You will be required to do lab work on usually every other day for the first 2 to 3 weeks. You will have a follow-up appointment scheduled that could mean you have to come to our hospital on a weekly basis. And then usually we shift that over to a monthly basis. And that appointment schedule usually lasts for about 6 to 8 weeks after you're discharged from the hospital. We want to make sure that you're healing well. And then after you're considered that first 6 to 8 weeks, you're considered a surgery patient. And then you're going to shift to the medical side of things. And a nephrologist transplant nephrologist will follow you to make sure that you're doing okay from the medical side of things with your transplant. Females and males of reproductive potential should consult their transplant team prior to pregnancy due to the increased risk of birth defects while taking immunosuppressant medications. An average deceased donor kidney transplant can last around 11.7 years, and the average live donor kidney transplant can last an average of 19 years. So some people, come to me thinking that this is a one and done situation, and it is not. So depending on how young you are, you might be looking at multiple transplants. You might be in the audience now, have already received a transplant, and you are on to your second transplant or third. I've evaluated a patient for their fourth transplant before. So there's people that have gotten a lot of transplants. Obviously, their bodies are, it takes a huge toll on your body to get a kidney transplant. So you can imagine getting multiple transplants would also take a very large toll on your body. I see a lot of people. I think I'm gonna just answer the Q&A when I'm all done, if that's okay with everybody. Yeah, I'm gonna answer some of these when we get finished this. All right. So we're gonna shift over to pancreas transplants. So there are a few different types of pancreas transplants. I would say the most common that we do here at Johns Hopkins would be a simultaneous kidney and pancreas transplant. This would be good for you if you are a type 1 diabetic. Sometimes it would be indicated for type 2 diabetics as well, especially if you have these symptoms. So blood sugar that swings from high to low, often without warning, frequent admissions to the hospital for diabetic ketoacidosis. That's when your blood sugar is very, very high and you're spilling ketones into your blood. And the average wait time for a simultaneous kidney pancreas transplant is an average of 1 year. So if you're someone that's already being evaluated for kidney transplant, but you feel like you might qualify for a kidney pancreas, it's easy for us to evaluate you for the pancreas part of it. So I would just reach out to your coordinator and see if we could potentially evaluate you for both. Pancreas transplant alone, this is for someone who is a type 1 diabetic. They have issues of their blood sugar going from high to very low, often without warning, or they're not very symptomatic, or they have frequent admissions to the hospital for diabetic ketoacidosis. And this is when they don't have any kidney problems. I don't think many of you here would qualify for that, but we do have some patients every once in a while that will come forward for pancreas transplant alone. And then the second common thing after what we call an SPK is a pancreas after kidney transplant. So sometimes a patient who has type 1 diabetes and end-stage renal disease has a live donor. So if you think you qualify for an SPK, but you have a live donor, we usually do the kidney transplant first using the live donor's kidney, which is a scheduled surgery. And then the patient waits for a deceased donor pancreas to become available. The time between a live donor kidney transplant and a pancreas transplant is usually about 6 months to 1 year. So we want to make sure that the patient is fully healed after they receive that kidney transplant with no complications, and they are ready to undergo another surgery while they wait for a deceased donor pancreas transplant. And the post-transplant pancreas, kidney pancreas, is very similar to when I previously spoke on the post-transplant side of kidney transplant. So for an SPK, the difference is you might have a few additional drains. You are probably going to be in the hospital a little bit longer because we want to make sure that your blood sugar is stable before we discharge you. So usually the range between 4 to 7, it's usually on the longer side, about 7 days. And your post-transplant appointment schedule could be a little more rigorous, a little more frequent than if you just got a kidney transplant alone. And that's all because when the pancreas is manipulated, we give you a new one. We really want to make sure that your blood sugar is stable, so that way you don't have any issues with your blood sugar following the transplant. All right, so we've talked about kidney transplant, we've talked about pancreas transplant, and now we're going to touch on liver transplant. So why is your liver so important? Your liver plays a huge role in your metabolism. It helps with your glucose regulation, triglyceride production, and protein degradation. It also is plays a huge role in digestion. It produces and excretes bile, storage, glycogen, vitamin A, D, B12, iron, copper. It has a huge function in your immune system, reticuloendothelial system, synthesis, plasma proteins, coagulation factors, hormones, thrombopoietin, insulin-like growth factor 1, angiotensinogen. Breakdown, it plays a huge role in breakdown and modification of bilirubin, of insulin, of toxins, and of drug metabolism. So your liver is very, very important to the function of your body. There are a number of indications for a liver transplant. So usually when patients come forward for liver transplants, they're very, very fatigued, unacceptable quality of life. They have recurrent variceal bleeding, intractable ascites. Ascites is when your belly gets really, really big, full of fluid. Recurrent or severe hepatic encephalopathy, spontaneous bacterial peritonitis, hepatorenal syndrome, or development of hepatocellular carcinoma on hepatic imaging. So I know a couple of you said you were also waiting for a simultaneous liver and kidney transplant. A lot of the times that's because you qualify for a liver transplant. So liver transplant when you qualify for a liver transplant, part of that evaluation is just to determine how well your kidneys are functioning. And so if we feel like your kidneys are also taking a hit, either you have an acute kidney injury or you have a chronic kidney injury, we will evaluate you for a kidney transplant as well. So here are some major differences between kidney and liver. We both use the United Network of Organ Sharing. And the United Network of Organ Sharing is the national transplant waiting list, helps match donors to recipients 24/7. But here's one of the major differences for liver transplant. Liver transplant organ offers are driven by the Meld Score, MELD. This is a model for end-stage liver disease. This was implemented in 2002, and it's based on objective factors. So the objective factors in kidney transplant is simply how long you've waited for a kidney transplant. But the objective factors for liver transplant are your Meld score, which is calculated by using your serum sodium, your total bilirubin, your PT-INR, and your serum creatinine. The score is an estimate of the patient's risk of mortality in the next 3 months. So organ offers for liver transplant are driven by how sick you are versus kidney transplant is how long you've waited. So that's just important. One of the major differences, you cannot live without your liver, but you can live without your kidneys. It's just not the best quality of life. You can be on dialysis. The range of a Meld score is 6 to 40. The 3-month mortality for a patient who has a Meld score higher than 40 is 71%. And then you can see as it goes down, obviously your risk of mortality decreases. So the higher your Meld score is, the faster you will get a transplant. And then the hospital stay for after your liver transplant, again, you will be on new medications, not much different than when you receive a kidney transplant. You will also have drains. Your hospital stay is a bit longer. We want to make sure that your liver is stabilized. And if you're here for a liver and a kidney transplant, you're looking at likely about 10 days. Again, the hospital follow-up discharge appointment follow-up is pretty rigorous as well. For that first 6 to 8 weeks, we like to see you pretty frequently. If you're doing really well and very stable, obviously your appointments will be few and far between. But if you are on the more unstable side and we just want to make sure that you're doing okay, we will bring you into the hospital quite frequently. About 85 to 90% of people who have liver transplants will be alive after 1 year, and 75 to 85% of people will survive at least 5 years after a liver transplant. And then the common complications after a liver transplant are all listed here. Bleeding, coagulopathy, and thrombocytopenia. What you can take away from that is bleeding. A lot of patients after liver transplant have bleeding complications. Hepatic artery or portal vein thrombosis, which would be diagnosed based on imaging. Some people have issues with hypotension, bile leaks, altered mental status, that's that hepatic encephalopathy. Sometimes patients after they get a liver transplant do have acute kidney injury where we would then have to evaluate for a kidney transplant. Fluid and electrolyte imbalance. Dehiscence is what I was speaking of earlier, which is when your abdominal area is quite large, and when we go to close it, there's a lot of tension on the wound, so it could open a bit. Graft thrombosis, graft rejection, ascites, infections, seizures, failure to thrive, recurrent disease, hepatitis C, or return to alcohol, which could be the reason that you needed a liver transplant in the first place. So liver transplant is driven by your Meld score, and the post-transplant complications could be much greater than receiving a kidney transplant alone. And then kidney transplant is just driven by the amount of time you've waited. So the main difference is that liver transplant, you can't live without a liver, but kidney, you have dialysis to back you up. And I think that pretty much covers liver and kidney transplant. So I was good. I left 15 minutes to spare.
Thank you, Michelle. That was wonderful. Thank you for your sharing this very important information with us. I can go through some of the Q&A. If you see one that you want to specifically answer, let me know, but I'll start with the first one from Mike. Has there been any upgrades in the immune suppression meds, less toxic or less meds?
So Mike, I believe there's going to be a topic about medications later on in the conference. And to answer that, not really. There really haven't been many upgrades. You are still going to be required to take a pill, and there's usually 2 to 3 different pills that are prescribed to you. And if you are not doing well with one of them, like you're having a lot of reactions or side effects, they can switch you over to different meds. So in that regards, yes, they have made some upgrades, but really in the long run, no, we've been using the same immunosuppressant meds for quite some time now.
Thanks, Michelle. Mark has a bunch of questions. I'm going to jump to one of his first, and we can come back if we need. I know a person who's actually had 2 kidney transplants, I believe, in less than 5 years. If the wait list is so long, how does one get 2 kidney transplants in less than 5 years?
Sure. So kidney transplant is I'll try to answer this, but this is kind of a very complicated question. So if someone's had 2 kidney transplants in less than 5 years, that likely means that they had a lot of antibodies from their first transplant, because anytime something foreign goes into your body, not just a transplant, it could be a blood transfusion, a pregnancy, any massive infection, your body develops what we call antibodies. And when a patient has a lot of antibodies, whether it was from that prior transplant or from a previous pregnancy, they do get listed a bit higher on the transplant list. And that's just a UN network of organ sharing, just put that into play. So that person who got 2 transplants in less than 5 years, it was either that they had a lot of antibodies the second time around, and so they were matched a little higher on the list, or if someone's transplant fails within 90 days of that initial transplant, they will go back on the list exactly where they started. So, or where they were when they were transplanted. So usually that would put them up higher too. So it's hard to answer not knowing the specifics of that, but those are two examples of what could have happened.
Thanks, Michelle. An anonymous attendee asked, please clarify per slide 10, is it inferred that if someone is active listed but not on dialysis, they are given lesser priority or no priority on the wait list for receiving a deceased kidney donor?
Yes. So when you are inactively listed for a transplant, I'm sorry. So when you're inactively listed, you're not up for organ offers. You're just accruing time on the wait list. If you're actively listed for a transplant, you just have to wait your time. So unfortunately, it's not that you're not given priority. It's just likely that you have not been waiting for very long. So you're not going to come up very high for organ offers. But when you're inactively listed, you can't qualify. You're not going to come up at all for an organ offer because you are inactively listed.
Thanks, Michelle. Joelle asks, with cardiomyopathy diagnosis for liver transplant, what is the acceptable ejection fraction to be considered for liver transplant?
So that, I believe, varies. I think an average, usually 35 to 40% ejection fraction would be considered acceptable. Anything below that, usually your functional status is pretty poor. When your ejection fraction is below 35%, your cardiac output, so how much blood your heart is able to pump to the rest of your body, is decreased. And if your heart can't pump blood to the rest of your body, then you are not going to be able to get blood to the liver transplant or the kidney transplant. So it wouldn't function very well. So we want to make sure that it's high enough for that. Sometimes patients with cardiomyopathy could qualify for a heart transplant as well. So if your GFR is your ejection fraction is below 20%, 15%, you could qualify for a heart transplant too.
Thank you. Wayne asks, I was evaluated for a kidney transplant in August 2018. At that time, I was told I was placed on an active wait list. I have done the blood work every 90 days and now 6 months, but I have not been contacted with any updates from anyone at Hopkins. I don't know who my coordinator is currently. I see my nephrologist on a regular basis. I'm not on dialysis. What am I to expect going forward? Should I be doing more to prepare?
Honestly, Wayne, no, it sounds like you are doing everything right. We will contact you when it is time for you to do your updates. But if you just want to check in with your coordinator, I am happy to tell you who your coordinator is. If it's not me, I will get you in touch with you. So you are more than welcome to shoot me an email or give me a call, and I'm happy to connect you with someone here at Hopkins. And I always recommend when you all know who your coordinator is, I highly recommend putting their number in your cell phone. You can either put it as Johns Hopkins, or you can put it as a nurse, or you can put it as the person's name. And I think it's just important to know who they are. So you could just check in and touch base with us, especially if things come up that we should know about for your medical, with regards to your medical history.
Wonderful. Malkia, I'm not sure how to say her name, says, I'm currently an active candidate for kidney transplant at Johns Hopkins. I've sent messages through my chart. However, no one has responded to my messages. My transplant coordinator is Miguel Briones. I recently moved to Missouri and want to remain multi-listed at Johns Hopkins.
Yeah, so Malkia, I recommend that you just shoot me an email and I am happy to connect you with Miguel. My chart is a funny little area. So as nurse coordinators, we are not part of your primary care team, which we've tried to fight multiple times. This is just like a technical thing. So unless you've communicated with Miguel through my chart before, there is no way for him to get that message. Unfortunately, I wish that this were different. But if you just shoot me an email, I will connect you with Miguel via email. And that way you can update your address or just remain connected with him. He's still a coordinator here.
Thank you. Valerie asks, is there a way to find out more on living donors for liver transplant?
Yes, Valerie, there is. And I'm sorry, I did not cover live donor liver transplant, but there is. So if you go to the liver transplant, the Johns Hopkins liver transplant website, there is a ton of information and contact information on who you could contact in order to get more information about that. I see one that I do want to answer.
Okay, go ahead.
Oh, I'm sorry. I just saw Dina asked, current research from Hopkins shows that the COVID vaccine is ineffective for transplant patients. And this is so true. So we did just publish a really great research on the COVID vaccine and how ineffective it is for transplant recipients because they are immunocompromised or immunosuppressed. So we are your question says, are you advising those waiting for a transplant to not get vaccinated? And actually it's quite the opposite. We really are promoting the COVID vaccine prior to receiving a kidney transplant because you will have a better response to the COVID vaccine. We are kind of toying with the idea of, at least for the kidney transplant population, of making it mandatory before we transplant a patient, because after you're transplanted, we can't go back and boost your immune system up. So we really prefer that both doses are given prior to transplant and at least 4 weeks before you actually receive the transplant.
And if you need more information on that, if you're not attending the 11:15 session on the COVID-19 update, it will be recorded and you'll be able to get that
Awesome.
information later too. So thank you. How about from Corey, what is the average lifespan of a liver transplant?
Corey, that is a really great question. And I'm sorry, I don't want to give you wrong information. I do a lot with the kidney and pancreas transplant team. So I will have to, if you want to shoot me an email with that question, I would be happy to get you in touch with the liver transplant team to kind of discuss the average lifespan of liver. I'm so sorry, I don't have that answer off the top of my head.
Thank you. Debbie asks if the presentation is going to be available for download, and then yes, I think I put that in the chat as well. The slides will be available along with the video after the event is over. And then we have about 1 more minute. So I'll go with Stephanie. My brother has been on dialysis for over 10 years and he has been cancer-free for 8. He continues to get updated tests, but no additional information regarding a transplant.
I would just say you're more than welcome to shoot me an email. I guess I'd have to know like the specifics of his case. Maybe best to talk about specifics outside of this webinar.
Thank you. And I'll do one more question. From Kathy, I heard that lack of transportation can be an issue in qualifying. Is there any assistance for this?
Not through Hopkins, but there is definitely assistance out there. You can usually, if you're like on medical assistance, there is plenty of transportation opportunities available to medical assistance patients. You can go through different transplant resources, but yes, transportation is huge. That is part of the psychosocial evaluation. We do want to make sure patients have adequate transportation to and from the hospital.
Okay, and that ends our session. I want to thank Michelle again for her great insights. Our next session will begin at 10:15. So please check your email, make sure you have the correct Zoom links for those sessions. And if you wanted to connect with other participants, the general meeting room is open in about 2 minutes. So you can log into that Zoom link I provided in the chat. And then Michelle, I think, is also going to be there for about 15 minutes. And that chat room will be open until 12 o'clock, but you can pop back in and out if you're going to your session at 10:15. And also please visit the triomaryland.org website to learn more about TRIO and the event website for more information on our sponsors who make the events possible. So thank you all. Thank you, Michelle, and see you at the next sessions.
Good. Thank you.
Bye-bye.